Hi kids, I wanted to discuss quickly chronic myeloid leukemia. This is both from undergraduate as well as postgraduate perspective. So we know chronic myeloid leukemia is characterized by translocation 922, which is the fusion of BCR and abelson gene, which leads to the formation of what we know as Philadelphia chromosome. Usually chronic myeloid leukemia has two phases, which is a chronic phase and initial indolent insidious chronic phase followed by a quick blast phase. Accelerated phase is no longer included in CML. Detection of CML is based on the finding of Philadelphia chromosome along with BCR abelson gene fusions and hematological and clinical findings as well. Now, patients are usually older males and somebody who probably might have received radiation in their past life. Chronic phase, 50% of the patients are almost asymptomatic and they're found incidentally. And the rest of the patients can have constitutional symptoms like fever, weight loss, anemia, night sweats, and some of them can also have splenomegaly. Sometimes they can be atypical presentations and they may have more symptoms. And when the patient is entering other stages like the blast phase, patient's constitutional symptoms get worsened, clinical performance declines along with symptoms of anemia and thrombocytopenia and increased WBC count showing up as well. Let's go to microscopy. First we are going to discuss in chronic phase what are the findings in blood. So the very first thing that you see is that is increase in WBC count, that is leukocytosis. It can be from 12,000 to 1 lakh, anywhere in between, and it is usually due to increase in neutrophilic progenitors and especially at the stage of myelocyte. So this is called an expansion or maturation arrest at the myelocyte stage. There can be absolute eosinophilia, basophilia, monocytosis as well. Platelet count is usually normal or maybe increased. Now coming to the bone marrow in chronic phase, it is usually hypercellular and due to granulocytic lineage, and again here the expansion or maturation arrest is similar to that of in blood, that is it is at the myelocyte stage. And there is no dysplasia in these granulocytic precursors, and blast count is usually less than 5% of the entire marrow. Lymphoid precursors, however, are significantly decreased. Megakaryocytes can be normal or increased, but again it is small dwarf megakaryocytes which are found in chronic phase of CML, and they are not as they are not normal size, but these are not true dwarf megakaryocytes as they are seen in myelodysplastic neoplasm. Bone marrow biopsy may reveal moderate to marked reticular fibrosis. Now coming to the blast phase. Criteria for blast phase in CML is more than 20% blasts to have to be found in PBF or bone marrow, or some extramedullary spread of blast to lymph node, CNS, or soft tissue skin anywhere in the body. The blasts can be of either myeloid or lymphoid lineage, but most commonly they are usually of myeloid lineage, and if lymphoid they are usually B cell origin. That was all about the CML and its diagnostic criteria, major findings. Coming to the prognosis, the TKI therapy has improved prognosis rate with remission at 75 to 90% of patients, and survival has significantly improved. Most important prognostic indicator for CML is the histological, cytological and molecular level. So that was all about CML. I hope you like these kind of videos. I will be making more of these. Thank you.